Hello, my name is Carolyn Rosales and I'm an oncology certified nurse. I will be presenting pain treatment in the cancer patient. BR is a 55-year-old healthy Caucasian female diagnosed with stage 4 breast cancer with metastasis to the left ribs 6 and 7 and T6 in the spine. She is to begin treatment of immunochemotherapy every 3 weeks for 6 cycles. She presents today with complaints of pain. She has tried to manage the pain with Tylenol and ibuprofen, but both measures have been ineffective. The hope is that the immunochemotherapy will shrink the tumors and help with the pain, but it can also cause its own pain. She will need to start a pain treatment plan so she can continue her quality of life. BR's pain is the result of her cancer diagnosis. Cancer pain differentiates from other pains as it pertains particularly to the cancer, and it can also be contributed to the responses of chemotherapy. People with cancer can experience enhanced pain because cancers secrete mediators that activate primary afferent nociceptors in the tumor. This causes an alteration of neurochemicals in the spinal cord. Tumors and bone metastases can also cause pain by applying pressure on nerves in the area, tissue destruction, and inflammation. Nociceptors are pain receptors, and afferent mean the pathway starts in the peripheral nervous system and travels to the spinal gate. Metastatic cancer can cause pain at the sites of metastases. Metastases to bone is common and contributes to pain in up to 50% of patients. The National Comprehensive Cancer Network suggests initial drug selection be based on pain intensity. A 4 of 10 pain should start with an opioid. A trial on non-opioid is unnecessary. Upon assessment, she complains of dull, persistent pain to the ribs, back, and left breast. She rates it a 5 out of 10 at rest and an 8 out of 10 with activity and upon palpation of the area. Diagnostic testing has already revealed she has bone mets in the areas where she is complaining of pain. She's alert and oriented ×4. She has normal sinus rhythm S1, S2, no upper or lower extremity edema. Her respirations are of normal rate and rhythm and depth. No complaints of cough or shortness of breath. GIs within normal limits and GUs within normal limits. Peripheral vascular is no numbness or tingling or loss of sensation in the upper or lower extremities. She is not able to do the things that she normally enjoys, such as nature walks, and states that it is hindering her quality of life. Being as non-opioid medications have not been effective, she is open to trying opioids, but wants minimal usage to control pain, to an acceptable level in which she reports is a 3 of 10. Although she is not happy with her cancer diagnosis, she does not report any signs of depression and wants to manage her pain so she can go on walks and keep a clear mind. Aside from what she will take for her cancer treatment, she does not take any other medications, nor does she have any other medical conditions. For the first pain medication I will prescribe will be oxycodone acetaminophen. BR has persistent resting pain level of 5 out of 10 that is hindering her from activities, so she needs an around-the-clock analgesic. She is opioid naive, so we will start with the lowest dose of 5 325 milligrams every 6 hours around the clock. Oxycodone binds to and activates the mu and kappa receptors in the central nervous system, producing analgesia. Another definition of mechanism of action is it binds to the central nervous system receptors, leading to a halting ascending pain pathways, thus inhibiting the pain perception. Acetaminophen inhibits cyclooxygenase, in turn decreasing prostaglandin synthesis in the central nervous system, thus reducing pain. Side effects can include respiratory depression, sedation, orthostatic hypotension, which can present as dizziness upon standing, nausea, vomiting, constipation, meiosis, withdrawal syndrome if medication is stopped abruptly. Acetaminophen overdose can cause liver failure, and acetaminophen can cause Stevens-Johnson syndrome, acute generalized exanthematous pustulosis, and toxic epidermal necrosis. SJS and TEN are medical emergencies. Drug interactions include alvimopant, which is for post-surgical constipation and do not use if opioids are used in 7 days or plan to use. Amphetamines can be beneficial as they can increase or enhance the analgesic effect. Anticholinergic agents, CYP4 inhibitors and inducers, CNS depressants. Carbamazepine may increase the metabolism of acetaminophen, and diuretics can diminish the therapeutic effect. Monoamine oxidase inhibitors, oxycodone, may enhance serotonergic effect, which can be dangerous. Multiple drug interactions, so always be sure that you review pharmaceutical sources such as UpToDate prior to prescribing a new drug. Being as with activity, her pain can spike to an 8 out of 10 severity. We need to give her something to address breakthrough pain and have something available as needed if she begins to experience pain before the next dose of oxycodone acetaminophen is due, so that she can maintain her activities of daily living and quality of life. For this purpose, my choice is morphine IR, immediate release. Being as she's opioid naive, once again, the starting dose will be 5 milligrams by mouth every 4 hours as needed for breakthrough or severe pain. The mechanism of action is the same as oxycodone, as they are both opioids. They bind to and activate the mu and kappa receptors in the central nervous system. Side effects, once again, include respiratory depression, sedation, neurotoxicity, which can be delirium, agitation, myoclonus, orthostatic hypotension, pruritus. I will never forget, after I had my second baby, they gave me morphine for my C-section, and my whole body was so itchy that first 24 hours. I think I almost scratched my face off. Nausea, vomiting, constipation. Opioid-induced constipation can get pretty severe and uncomfortable, and also she will most likely be taking Zofran or ondansetron for her chemotherapy to manage the nausea side effects, which can also have a side effect of constipation. So it's important to assess bowel function, urinary retention, and meiosis. Possible drug interactions include anticholinergic agents, CYP4 inhibitors and inducers, CNS depressants, agonist-antagonist opioids. If they're given the agonist-antagonist opioid along with the morphine, which is an agonist opioid, it can inhibit or not allow the agonist opioid to do its job effectively. Monoamine oxidase inhibitors, alcohol and benzodiazepines, as they can cause sedation, it can increase the sedation. Antihistamines as well. Hypotensive agents, since the medication can cause orthostatic hypotension, and then you give them more hypotensive agents, it can drop their blood pressure even more. Once again, multiple drug interactions, so always be sure to check your pharmaceutical sources before prescribing new drugs. Patient education will include the side effects of drugs, as well as a handout, which it can either be electronic or paper. Patients only retain so much when they're in the office with us, so I think it's important for them to have a reference to refer to at home if they have any questions. We'll also instruct them not to take any medications, including over-the-counter vitamins and supplements, without checking with the provider first. Lots of times patients think that vitamins and supplements don't count, but they do count, as they can have interactions with metabolisms of different drugs. Since the opioid can have neurotoxic effects and also respiratory depression, we want to make sure that she knows to report to the ER if she starts to have any respiratory depression or any delirium side effects, or also the rash and blisters with the peeling skin, as that is how SJS and TENs can present, and they are medical emergencies. I'm not quite sure on other states, but I know in California, I noticed that when an opioid is prescribed, naloxone, also known as Narcan, is prescribed. And so just instruct the patient that this is an antagonist against the opioid, and they are to use it at any sign of respiratory depression or altered mental state, and then they need to call 911 afterwards, because it is a short-lived drug. Just let them know to take medications as prescribed. A lot of times people confuse that as needed part of the medication thinking that they can just take it whenever and they don't need to wait until the hour mark, as it's prescribed every 4 hours as needed, meaning that she still needs to wait for the 4 hours and kind of like can take it if it's needed at that 4-hour mark or beyond. A lot of times we allow a 30-minute window, so at that 3.5-hour mark might be okay. One time my grandpa was on Dilaudid for his pain, and he told me, "Do you see that on the patio?" There was nothing on the patio, and I asked him how he was taking his Dilaudid, and he said, "As needed." And so he had taken a few more than needed in that 2-hour span. So just making sure that they know that as needed isn't just when they need it, it needs to meet that hour mark. Also, to store in a safe place away from children, preferably in a locked location, as it can be very dangerous if the children do ingest this medication. If pain is not controlled, it's important that they contact us in order for a reassessment of the pain and to further evaluate the plan. Especially with an oncology patient, it's important if new pain develops, because it could mean worsening of their condition or their cancer diagnosis or more metastases. Many adjuvant and alternative therapies, many drugs can be used as adjuvant therapies to complement the effects of opioids. These include antidepressants like tricyclic antidepressants, anti-seizures such as gabapentin, and topical anesthetics such as lidocaine. They can all work on neuropathic pain. A lot of times when our patients start to get the neuropathy from their chemotherapy, we definitely add in gabapentin to try to help with that. Other adjuvant therapies, like I said, when I was mentioning the drug interactions, that amphetamines can actually be beneficial. They can enhance the opioid-induced analgesia and counteract opioid reduction. So something like Ritalin is an example of that. Glucocorticoids can be used to reduce inflammation if it's present, if the inflammation is what is causing any of the pain. They're also beneficial in cancer patients because they can improve the appetite and then just give a general sense of well-being. A lot of times we give something like dexamethasone or prednisone with our cancer treatments or as a pre-treatment to the chemotherapy to try to prevent any reaction to the drug. And a lot of times it helps the patient stay feeling good for the first 3 days after chemo, and then they explain it like they got hit by a bus after that 3rd day, as the steroid starts to wear off and everything starts to hit. Biphosphates can also be used to reduce bone pain. They're not approved for treating pain in patients with bone mets, but a lot of times patients with bone mets or somebody like with multiple myeloma that affects the bone marrow, they are given biphosphates to treat hypercalcemia. And so when they get that biphosphate, they reported a reduction in bone pain. So it's not indicated for that, but it does seem to help the patient when they have bone mets. Other alternative therapies that aren't like Western medicine type of therapies that you're not ingesting a pill for include acupuncture, aromatherapy, meditation, and massage. They can all be implemented to help with not only the pain but other side effects associated with pain medication and or the chemotherapy. In summary, it's important to work with the patient to complete a thorough assessment of their pain that include physical and neurological. Pain is what the patient's perception of pain is, and it's what they say it is at the time and where. Just since there's so many different pain pathways, there can be referred pain. So maybe the pain is not at the location of the tumor, it's somewhere else, but it doesn't mean that it's not the tumor causing the pain, or it doesn't mean that the pain is not real. Diagnostic testing as well, and psychosocial aspects. Like our patient mentioned, the pain was hindering her quality of life, and we want to make sure that with her new diagnosis that she can maintain the best quality of life needed to get through treatment. I think it's also important to work with the patient to come up with an effective treatment plan, as this will help the patient feel that they are a participant in their care and help with adherence to plan. Now, patients want to be involved, they want to have a say in what they get. And as mentioned in the beginning, she tried non-opioids, so she was willing to try opioids. Not everybody is keen on just popping pills, I guess you can reference it to. So it's important that they're part of the treatment plan. We'll educate the patient on the medication, side effects, precaution, and when, where, and how to seek further care if needed. I mentioned making sure she knows to present to the ER if she has respiratory depression, and also returning to the clinic if the medication is ineffective. Leading into, it's important to make follow-up visits to assess the effectiveness of the current treatment plan and make adjustments as needed so the patient can have a good, effective quality of life. I think it's always important for them to have their next appointment before they leave the clinic, because a lot of times the patients fall through the cracks, or they don't report new pain, or they don't report new things. But if you already have that follow-up visit to assess the plan that was put in place, they come back to their appointment, and then you can be reassessed, and it gives you that interaction with the patient to assess that. And these are my references. Thank you very much.